this person is afraid to go back to her room because she thinks there's a man that is waiting in her closet and he plans to hurt her. And she cannot be redirected, even though the family member sees nobody is standing in the closet. So what conditions might be represented in this case? You can go ahead and type in the chat box. Delirium. Good. Electrolyte imbalance. Very good. UTI. Yes, you guys have experience. Thank you. Okay. Well, a lot of us have seen these conditions, and unfortunately, in cases like that, and it's based on true scenario, actually, it's based on multiple true scenarios. The people have often been misdiagnosed or mislabeled as having neurocognitive disorder, also known as dementia. Because of so many cases like this, it's really important to hone in our skills on differentiating depression, delirium, and neurocognitive disorders so that we can assess and manage them carefully. So those are the objectives: to differentiate between the three conditions, identify appropriate screening tools for disruptions to mental functions, and implement therapeutic communication with people who have a disruption to mental functions. So in a nutshell, I made a table to differentiate the main differences between depression, delirium, and neurocognitive disorder. So depression really is a disruption to their affect, their mood, their emotional components. And it can have a definitive or a gradual onset. There may be, according to diagnostic criteria, there needs to be 5 or more core depressive symptoms in order to diagnose. Now, as an interprofessional team, we typically will let the physician and PA, psychiatrists, et cetera, the nurse practitioner do the diagnoses. However, we can inform with different assessment tools to help in the diagnostic process. Depression also has limited scope of cognitive impairment. However, we may see some effect on executive functioning, such as judgment, planning, problem solving. And depression can resolve with or without treatment, depending on what the cause is. In contrast, delirium really is a disruption to attention and cognition. Those are the two core aspects of delirium. It is a sudden onset and it's temporary in most cases. And it is a consequence of a medical condition. The person with delirium may have delusions and hallucinations. The delirium may be intermittent and global impairments, but a lot of times after the delirium subsides, people will remember the symptoms even after the symptoms resolved. And the symptoms can improve with treatment of the underlying medical conditions. So delirium really is supposed to be considered a medical emergency situation that warrants a thorough evaluation and medical treatment. And then neurocognitive disorder really affects attention, cognition, and memory. Because remember, without attention, there is no memory. So most neurocognitive disorders have a gradual onset, although they can be sudden if there is like a stroke, a vascular type of neurocognitive disorder. The impairment may be associated with limited awareness of the person and limited recall, especially of short-term memories because of the attention deficit. Neurocognitive disorders do tend to be progressive with global impairments. And again, it affects memory and cognitive or executive functions. Some people with neurocognitive disorder can also have episodes of delirium, but they shouldn't be blurred. They should be treated as two separate things. And neurocognitive disorders do tend to be progressive over time, but not always, as most of you know. They may lose orientation to person, place, and time. So the disruption to mental functions, all three conditions, in order to really think about it carefully, it's important to address ageism, because ageism is present, unfortunately, in our healthcare system and in our society. So Butler coined the term ageism. So he was the first person that really wrote about it, which is prejudice and discrimination against older adults, which does adversely affect their health because of two reasons. Number one, the person may internalize the cultural perceptions and come to believe the same thing about themselves, which limits their participation in life. And then that can cause further decline in mental functions. I had one person tell me, what is the point of going out and working when everybody that's hiring looks at you and says, well, you're old, you can't do it anyway. Pretty soon I start believing I can't do it too. And she got a tear in her eye. So it hurts. The ageism hurts. But the other problem, and from our perspective, is that these stereotypes can actually lead providers to dismiss health and wellness concerns about their mental functions as expected or normal age-related changes. So we're going to be talking about these disruptions to mental functions that are not normal age-related change, and they really should be assessed and managed carefully. So I have a statement of need really for each of the three conditions that really kind of taps into our affective domain of learning. There's some interesting literature about each one. So depression. What is the reason we need to address this and carefully assess and manage it? Because did you know that Casey found that older adults have approximately double the rate of suicide when compared to the general population? That's alarming. And interestingly, there are many studies besides Casey, but they found that many of the people who committed suicide or tried to saw their provider within days prior to the suicide. So therapeutic communication is really important. Referrals are really important. That's the kind of thing we're going to be talking about today. Also, people have been misdiagnosed and mislabeled with depression or anxiety when they actually had physical symptoms. So we can't use depression or anxiety as a wild card or a default label. We really need to investigate the medical and the mental functions. So people that do get misdiagnosed are very hurt because they're not heard and listened to and understood. And so what happens is they can get misdiagnosed without doing a depression anxiety assessment or a screening tool. And I'll show you how simple and easy some of these screening tools are if you haven't seen them yet. And then conversely, depression is undertreated among older adults because depression can be manifested as physical symptoms. So it's really hard to differentiate if it's a physical condition or a mental functions condition, which warrants a thorough assessment of both mental functions and their physical or biological well-being. So we have a statement of need for delirium. This is kind of interesting. In a large study by Lindroth, there were, I think, 92 hospitals that reported to their survey during a conference on delirium. They reported that 16.4%, they found 16.4% of hospital patients, there were cases of delirium at 8 a.m. and then 17.9% at 8 p.m. So there's a little difference between day and night, a little more common in the evening. But delirium is often unrecognized, undocumented in 60% of cases, according to Ofeng, Xu, and Anu. So it's often misdiagnosed, which Herkus and Raman found. And the range in the literature review that I did found between 41.8% to 73% of studies were unrecognized or undocumented. And that's because there are many complicating factors, as a lot of you have experienced, comorbidities, hypoactive delirium state, where they're just very kind of almost sedated. And so they might not pick up on it. And lack of time is very common. There's also diagnostic overshadowing. If somebody's been diagnosed with a psychiatric diagnosis previously, sometimes they attribute the delirium symptoms to the psychiatric diagnosis, when in fact it might be a medical situation going on with this person. So we also have a statement of need to discuss neurocognitive disorder. This was an alarming case study. I know case study doesn't have high rigor, but when I read this, I thought, oh, I need to share this. This is really kind of sad. So this one lady was misdiagnosed with Lewy body dementia because she was having visual hallucinations, but she did not have any other indicators of cognitive impairment. Well, they ended up putting her on antipsychotic medication, which ended up causing postural instability and Parkinson's-like symptoms. Well, she found out later, went to the eye doctor and got re-diagnosed with Charles Bonnet syndrome, which is a visual impairment that causes pseudo-visual hallucinations. Well, once they got this new diagnosis, they started weaning her off the antipsychotic medication, and voila, she recovered fully physically. But in the meantime, she was, hurt. Her trust in the healthcare system was impaired. And I can't even begin to comprehend what it would feel like to have a diagnosis of dementia when I don't have that at all. So that'd be kind of scary, because she probably changed her whole perception of her future. Scary deal. So as we can see, there's a really strong need for all of us to work as a team and differentiate delirium, depression, and neurocognitive disorders so we can effectively manage it. So a little bit more about depression. We do know there needs to be a presence of 5 or more depressive symptoms, and they're all listed there. So we can have emotional changes, but we can also have appetite changes, changes in sleep. Some people can have too much movement or not enough. It can be loss of energy, feelings of worthlessness. So sometimes depression can manifest itself both as an emotional disruption and biological or physical disruption. Now, delirium is a temporary disturbance in attention and cognition. It's fairly abrupt, and it's not attributed to a neurocognitive condition. So it is a disturbance of another underlying medical condition. And the Herkus and Raman had to identify the hypoactive type and hyperactive type. So you can see both types of delirium. And we'll get into that a little bit more. And then neurocognitive disorder really is a syndrome. In the past, we called it dementia, and there are many different types of neurocognitive disorder. I was speaking with a lady whose husband had a neurocognitive disorder, and she was sharing some information about how he was doing. And I said, I'm really sorry he has this neurocognitive disorder. And she said, thank you for using that word instead of the other word. So there are some people that feel pain when they hear the word dementia. It's hard. So I've been trying to use neurocognitive until somebody tells me differently. But this type of syndrome can be from the most common one, which is Alzheimer's disease, and then vascular or mini strokes, Lewy body dementia, and Parkinson's, frontotemporal, traumatic brain injury. It can be from HIV infection or substance or medication induced, like alcoholism, that disrupts the B12 absorption. Huntington's chorea, any prior disease, other medical conditions. So in a neurocognitive disorder, it really is an underlying pathology that causes typically a progressive change in cognitive issues. So how do we assess? Assessments. There are a lot of assessments for depression. There's the patient health questionnaire, and you will see this one used in the literature, evidence-based research studies quite frequently. I think that's a really good one to use in your practice, in all of our practice. You can take those questions and build them into your discussions naturally. They do not have to be read verbatim. The geriatric depression scale is another one that I like, in particular with older adults. And I'll just show you a quick picture of this. This is based on yes/no questions because it's only a screening tool. It is a screening tool. And there are 15 questions. I give this test repeatedly to PT students and medical students during a presentation with them and have them time it. And most of them take about 1.5 minutes to get through it. Now, with a real client or patient or resident that you're working with, it might take 2 to 3 minutes. But nonetheless, that's a pretty short period of time. And this is enough time to find out if they are at risk. So basically, more than 5 points is suggested of depression. And if it's more than 5 points, it does warrant a follow-up comprehensive assessment by somebody who is trained and it's within their practice domain to do a comprehensive assessment. All right. So as you can see, that geriatric depression scale is pretty quick and easy to use. I've used it many times and it has worked quite well. There's also the Beck Depression Inventory, the Cornell Scale of Depression and Dementia. And then you also, again, it's important even with depression to rule out these other physical or biological medical conditions, because sometimes if somebody's feeling fatigue because of, let's say they have cancer, for example, they may feel that fatigue as depression, and maybe they actually had cancer. So we still need to do the mental functions assessment and the biological assessments. There's a specific assessment for delirium. There's assessment tools and process. Herkus and Rama and Hadab said, regardless of discipline, so we can all work together as an interprofessional team to assess delirium. And they have a process called the confusion assessment method. It is a process or an algorithm with validated screening process. And the diagnosis of delirium requires the presence of features 1, 2, and either 3 or 4. So 3 of the 4. But they definitely have to have acute or fluctuating course. They need to demonstrate inattention, and then 3 or 4. So either disorganized thinking or altered level of consciousness. And then the tool that goes along with it is the 4AT. And if you just type that into your Google, it'll pop right up for you. It does align with the CAM. So neurocognitive disorder is assessed with many different tools. And first, we still talk about the mini mental state exam. It's very old, but even in the new literature, they're comparing the new assessment tools still to the mini mental state exam. And I'm still seeing this used in some of the ER visits. So it's still very common. There's also the MADIS dementia rating scale. And then there's the Montreal Cognitive Assessment. It's a one-page assessment. That one you need special training for because it's supposed to be a screening tool. It only takes 10 minutes. You know what some people were using it for? They were using it in court to determine if somebody was cognitively impaired enough that they would need a conservator or a guardian. And so they were using it legally in a legal state. But you can't use screening to determine if a person is a vulnerable adult because of their cognitive impairment. So when MOCA found out that people were misusing the screening tool, they had training in there. Anybody want to add in your experience? Jump in if you want to add anything in. All right, and then the mini cog, it's another short assessment. We actually use it with the GWEP grant for a wellness assessment with older adults. And basically it's, you say the 3 words, kitchen, baby, and another word, sorry, I'm blanking. And then you do a clock drawing to see if they can draw a certain time on a clock. And then you come back and have them recall those 3 words. It's a very short, brief screening tool, and it just warrants if there needs a follow-up. Then there's the Alzheimer's disease 8, which is a self-reporting screening interview, and you can use this with a person who is demonstrating maybe some cognitive function impairments or with their caregivers. They also have the short blessed. This is just a screening for mild cognitive impairment. This one takes a little bit longer, but it's still a screening tool. The global deterioration scale, it really gives, this is helpful to caregivers because it helps you determine how much support they need. And if it ends up that they really should have 24-hour care, then the family can say, well, do we have the resources to give 24-hour care at home? If not, maybe they want to start thinking about other resources and living situations, but it helps them make those hard decisions, and they are very hard. And then there's the St. Louis University mental status exam, also known as the SLUMS. It's a little bit more sensitive than the mini mental, takes about 15 minutes. I would say the ones I've seen the most are the SLUMS and the MOCA, the mini mental and the blessed, but maybe you have different experiences. So if those screening tools for any one of those conditions shows that there may be a problem, it's really important for follow-up and immediate action. So if there's a risk for depression or diagnosis, we really want to get immediate psychological consultation and intervention, especially because older adults have that higher rate of suicide. And if they have that support in the services surrounding them, it can give them a higher degree of self-efficacy that, maybe I can get through this. Maybe I do have more people around me than I realized. And then same thing with delirium. The literature, the authors, the researchers said that we really need to look at delirium as a medical emergency and urgently do the diagnostic workup for precipitating factors. Now, there may be situations where somebody does have a neurocognitive disorder. They might be living in a memory care home. I use memory care home because they would rather call it a home than an agency or facility, most of you, I think. So they might be in a memory care home and have some cognitive impairment, but then they're starting to demonstrate delirium, symptoms of delirium, maybe say at 5 o'clock before supper. Well, if this happens fairly frequently and it always gets better when they eat and get some rest, so they go eat, they get their blood sugar up, and they lay down after they eat for about half hour to an hour, and the symptoms resolve. Well, those caregivers kind of know that person's pattern, so no, they may not need to send them to the ER if they can effectively manage that and they know what the cause is, fatigue and low blood sugar. But otherwise, if you don't know them real well and it's a new onset and they're actively hallucinating or profoundly almost sedated and not responding to things, that really needs to be checked out because there might be something going on. They could have had a stroke. They might have an infection. I mean, the possibilities are quite broad. And I'm sure a lot of you have had some unusual causes of delirium that maybe surprised you as well. And then same thing for neurocognitive disorder, we need to do referrals for that comprehensive assessment. If there's a screening tool that indicates neurocognitive disorder, we really should follow up, not just with a screening tool, but a thorough assessment. And that can go through psychology, speech language pathology, counseling, medical doctors, nurses, OTs can do them. Social workers absolutely can help with the assessments. And then we also need to plan for long-term supportive services, OT and PT for caregiver training. I'm always surprised how many caregivers, informal caregivers, are caring for their loved one, and they didn't have any support or instructions or guidance on even how to caregive, how to provide that kind of care. And then home care is really important. I know we have a lot of home care agencies, but some of these rural communities still have a major shortage of home care services and respite services. So the more services we can get to these people, the better. We do have somebody from Horace, North Dakota, and Jamestown. What are your resources like in the community for home care and respite? Anybody? You can speak or type. Let's see. See if anybody. Oh, I've got a few questions here. Okay. Smaller community, but you have really good resources. Thank you, Melissa. All right. I'm going to pause for a moment and go back to that question about the HIV infection correlate affect with a cognitive concern. There are rare cases where somebody has had an HIV infection, could be, and I'm not sure which type of HIV specifically, and it just got an infection that followed up the nervous system and affected the brain with encephalitis. And the people I've seen with that type of neurocognitive disorder did not progress. They just stayed at that function, and they probably had short-term memory problems, but were able to do other global functions quite well. All right. Any other questions? Comments? All right. I will keep going. Thank you. All right. So communication strategies. Yes, there are different communication strategies to use with each condition. For depression, empathy. Empathy is by far the most important thing to do. Validate their feelings and experiences, draw out their prior successes in coping to support self-efficacy. So we might say, I'm sorry you're feeling sad, or I can tell you're feeling sad today. Have you had a time in your life before when you felt sad and you were able to cope with it successfully? Could you tell me about that? And then they can build and tap into that to remind themselves, okay, this is hard, this is sad, I just lost my loved one, and now I'm retired, I'm in a new community, I don't know anybody. Okay, you know what, this happened to me when I was 25, and I got out of that. Okay, maybe I can get out of this again. So really validate those feelings and tap into self-efficacy or prior successes. Now, if somebody's having active delirium with delusions and or hallucinations, you do not want to do reality orientation because it hurts them, it scares them, and it is their reality right now. So the lady that felt that there was a man in her closet, in her room, actually was my grandma. And I could tell it, you just knew, she just knew there were two men in her room waiting she thought they were going to rape and kill her. And I mean, it was her reality, and she was scared, and she knew they were in there. So there's no way you can redirect. but she ate, her blood sugar got back up. I sat down with her, I talked, I reminisced, I had her look through a magazine, and pretty soon she eventually went up to her room and found nobody was there. The next day she recalled it. But you know what happened? She had a blood sugar issue. And that's why the delusion subsided after she ate. She got better, but she remembered it the next day. And it was scary. It's really scary when that happens to them. The neurocognitive disorder, I do hear a lot of people say, "Oh, do you remember when?" Well, we don't want to say that. That's not that, just eliminate that from our vocabulary because that's scary and hurtful to them. Instead, we try to use visual cues and photos, and we don't say, "Do you remember?" And, "Oh, isn't this a neat photo?" And sometimes the photo can spark really nice memories for them, and that's comforting to them. If not, just enjoy the photo. And then simple verbal sentences, pause frequently to allow processing time. So one thing that happens with neurocognitive disorder is that the processing time slows down. Some people may need pauses to give them a little more processing time. And then you just pause, and you don't have to do it, awkwardly. Just slow down, which is really hard for healthcare providers because I tell you, when I was in practice, that was the hardest thing for me to do, was slow down, because I had multiple people I had to see and they were waiting for me. But I guarantee you will go slower if you go faster. So go slower, give them time to process the words, and then they can usually respond. Now, if they've lost their language skills, of course, use the visual cues, the demonstration. You can do gentle but firm hand over hand cueing to help them get their hand in their sleeve. But that works quite well most of the time, neurocognitive. And then therapeutic communication strategies, again, the calm, low tone, separate the words and sentences, and do it therapeutically. It helps them feel heard and understood. You can do this with all people. So I know it sounds elementary, but in practice, we're in a hurry. And I have so often heard people work with somebody who's in a state of delirium, and their voice tone gets abrupt, it gets high, they get louder, they get faster, they're more intense. And I'm like, "Oh, you're making it worse. Stop it." Just relax, calm, low tone. I have to remind myself that all the time to slow down. And then these simple motivational interviewing techniques really do work with everybody, regardless of their condition. So we paraphrase. So you're saying it's important to, or reflect on the feelings. It sounds like you're feeling worried. Is that correct? Yeah, I'm really worried about what's going to happen to me. The doctor just said I have Alzheimer's disease. So, let's talk about the feelings, show that empathy, and then open-ended questions. I want to understand more. What else can you tell me about maybe the loss that they're talking about? And then Csikszentmihalyi, the father of flow theory, says that you can instill happiness and peace, a sense of peace, by redirecting people to a meaningful activity, because as they engage in activity, it organizes information in their brain with that activity, and that causes a sense of calmness. So there's actually a psychology going on in the brain that affects them physiologically, that emits a sense of happiness. So he's called the father of happiness. So another thing we want to pay attention to with each other, especially as interprofessional team, is mitigating ageism. So in the first column, you'll see poor communication, also called microaggressions, for ageism, which would be naming the age. An example would be, they're an older adult, so we should automatically do a depression screening. No, it's not normal to have depression as an older adult. That's ageism. Instead, we want to convert that wording with each other and with families and to the people we're serving with good, respectful communication by addressing the function, not the age, the function. So the person, reported sadness and a decreased appetite, which can be signs of depression. So we should do a depression screening. That would be more respectful of what's going on, and not ageist. All right, going back to the second example of poor communication or microaggression that shows ageism, is saying they are over 80, which increases their risk for delusions. So we should do a cognitive screening with everyone over aging or over 80. Well, that's totally ageist. You know, you want to read that to Warren Buffett? I don't think that would be very well received. So instead of talking about the age, we want to show that we're addressing the function, not the age. So they are showing signs of self-care neglect and forgetfulness. So we should do a cognitive screening because those are two early signs of cognitive dysfunction. So let's be careful with ageist comments. And I hear it every day. Oh, I'm getting old. I need glasses. No, my vision's getting impaired. So we hear that all the time. We're not going to fix it today, but let's just be aware of it. So we'll go back to a case scenario. We'll do this case scenario and then we'll go back to the original case scenario. A retired farmer who is confused is trying to leave a memory care assisted living home because he believes he needs to go feed the cows. But he actually sold the cows like 20 years, 30 years ago. He has moments of clarity when he says he's sad that he can't see the cows anymore. Verbal redirection does not help at all. This is based on a true story. What can any interprofessional care team member do? And you can type into the chat box, if you would please. What can we do? Any interprofessional team. How do we handle this situation? How have you handled it? So if you can type in the chat box or you can speak. I really like it when people speak. What would you do with this retired farmer? Oh, I love the pet idea to nurture or care. Absolutely. If this person had cows, maybe another farm animal or pet would be good. By the way, Kristen Vetter brings her mini horses over to the memory care facility in memory care home, in East Grand Forks. Her little ponies, yes, right into the building. Redirect, focus, reassure him that the cattle were taken care of this morning. Yes, I did do that. What else can you do? Go on a visit to a farm or tour a creamery. Oh, that'd be nice. Yeah. Yeah, work with the activities department for sure. Or family. What else can we do? All right, so how do we redirect? Well, we can redirect with activity first. That's like our immediate reaction. Have farming magazines on hand and start paging through it with the resident. Bring in another resident to look at the magazines together and talk about it. Offer a cup of coffee because that might be the normal routine before feeding the cows. It's very familiar. Bring in a newspaper, card game, or something that's meaningful to that individual. It needs to be meaningful. Or try to keep the resident engaged in the activity until the delusion or extreme sadness starts to subside, and or other treatment can be implemented if needed for the condition causing the delusion. So it could be a situation of delirium. It could also be, you might have some depression going on. So we do want to do all those other assessments. All right. So now we're going to go back to the original case scenario. This person, I'll just call this person Helen. was acting paranoid, and now I'm added that she's living in assisted living, and she thinks there's a man in her closet who wants to hurt her. So what conditions do you think are represented here? What do you think is going on with her? Well, it seems to be delirium. So the nurses picked up on it because it was abrupt onset. It was something different. Anyway, so a nurse conducted the CAM, which showed the presence of features 1, 2, and 3. So acute, inattention, disorganized thinking. 1, 2, and 3. The doctor ordered biomedical tests, like a urine analysis, showed the presence of leukocyte esterase, which is the presence of white blood cells and red blood cells. No typical signs of stroke, such as hemiparesis, dysarthria, dysphagia. So they ruled out stroke. Her temperature was up, though. Her heart rate was up, her respirations were up, and her blood pressure was up. And then the family said that Helen doesn't like to drink water lately because she does not want to bother the staff, assisted living or SNF staff, to help her to the bathroom. And it's getting harder for her to speak, to ask for help. And her muscles have gotten more rigid lately from the Parkinson's, and she's needing more help to the bathroom, to transfer to the toilet, pull her pants up and down, manipulate the toilet paper. So what conditions going on with this one, would you say? What do you think? Yeah, urinary tract infection and dehydration. That is correct. All right. So, yes, in this case, it was a state of delirium, and we have to respond to her. So, how do we react to her? We paraphrase, reflect, ask open-ended follow-up questions, help her engage in an activity to redirect her, and what referrals are indicated. How do we manage this? Well, here's what we did. So the doctor did admit Helen to the hospital for UTI with related delirium. She was treated with an antibiotic, IV fluids, diuretics, and redirection activities. PT did manual therapy to reduce the muscle rigidity and promote mobility for toileting. OT taught her compensatory strategies with a walker to support independence with toileting. And Helen was able to get herself to the bathroom with modified independence. And she had a gadget that she could use to wipe herself because she had a hard time reaching and manipulating her fingers, but she could hold a bigger gadget with a larger handle. Speech language pathology worked with her on communication so that she could improve. Even though she had Parkinson's, she could improve her speech with those speech exercises to articulate her words better. And they also gave her a communication board for times when her speech was more difficult. As you all know, with Parkinson's, they have lots of ups and downs throughout a 24-hour period. And then her cognition cleared almost immediately with the antibiotics. But she did later remember the delusion about the man in her room who was going to hurt her. And she recalled it. She stated later in a visit with the social worker that it was a false thought. She held her head down, and the social worker replied, "I bet that was a scary experience for you." And Helen exclaimed, "Really, it sure was. I'm afraid it'll happen again." So right now, Helen felt understood just because the social worker said, "I bet that was a scary experience for you. Thank you for understanding me. Thank you for acknowledging it." You know, it's such a simple thing to say, but we don't say it enough. Things like that therapeutic reflection. The social worker reassured Helen the team is pretty sure that the UTI, the urinary tract infection, caused a disruption in your thinking ability, which actually happens more often to people than we realize. So what do you think is the best thing you can do to keep your kidneys and your brain healthy? So she gave it back to her through self-efficacy. And Helen explained, well, I can drink more water now because I can actually get myself to the bathroom safely. And I actually want to do my exercise now because I understand why they're so important. People don't do exercises unless they understand why they need to do them. So in summary, it's really important to differentiate the three conditions: depression, delirium, and neurocognitive disorder. They are not normal age-related changes. They are interruptions to mental functions and should be treated as such. It's really important for all of us team members to do our parts with the assessment and share the results with the team for comprehensive evaluations from a team perspective. And then again, that communication is really appropriate. What you might use with somebody with depression would be very different than somebody with a neurocognitive disorder or delirium. And also referrals and services, supportive services and interventions to help manage the overall quality of life.